Ready? All right. Cardiology, part 2. So this one, I can actually go quickly because if you look at the management for STEMIs and unstable angina, they look an awful lot like the management for a STEMI. In fact, our antiplatelet therapy is the same. Anticoagulation, again, you can look at whether you want to do unfractionated heparin or low molecular weight heparin. You want to make sure that you're covering all this just like you do in a STEMI. You're going to use the ACEs, the beta blocker. You want blood pressure control. You're looking at trying to manage your cholesterol as low as you can. Smoking cessation. It's all the stuff we do every day that we're now turning into Smurfs, right? Because you're blue in the face. And so you want to look at that. But the questions are, who do you evaluate with unstable and the non-STEMI? Exercise, stress testing, who do you early angiography, who do you consider for revascularization? And you look at those people that are at the intermediate or high risk and say, those are probably people we need to intervene earlier rather than later. And then you'll have those patients that you take them to cath and they have no clot. And that's up to 10%, rapid clot lysis syndrome. So when you look at who do you want to evaluate, you can look again. Here's another TIMI study, talks about threat. Someone who's having 2 episodes of chest pain in 24 hours is telling you they're not stable. So you need to do something further. And again, why do we do this? Because you could look at in-hospital mortality, comparing high to low. It's about 11% the difference, absolute mortality. And so it's important to pick that out, those patients out. And if they're low risk, they probably can be stratified to conservative therapy. If they're still having symptoms, then you would go on to further evaluation. If they're high risk, you're probably going to do evaluation, probable cath, and possible stent. So now let's talk about those patients that you know have coronary artery disease. They're more of the fixed coronary artery disease. Patients who've had a cath already and they've had a stent. These are the people who fall into that category. Second leading, again, cardiovascular leading cause of death. And then we're going to look at who do we revascularize. Basically, it's on the extent of the myocardium that's at danger. And you want to look at, I always love biostatistics. Remember pre-test probability, post-test probability? Yeah, they're going to ask us a question or two about that. And we all go, yeah, So if you look at this in the patients who have low probability disease, if you have a positive test, it's probably a false positive. On the other hand, if you have a high probability disease, so the person is, say, gee, I really think they have coronary artery disease, and they have a negative test, it's probably a false negative. So just kind of think about your pre and post-test probabilities, and you can help us when we look at some of how we diagnose the coronary artery disease. And we can do things like exercise stress testing, pharmacologic stress testing. If you want to get the calcium artery score, still debatable, maybe useful in the patients who either have a low probability or have a normal scan. I'll give you an example. A lady that walks every day. She started walking around the track. She got some chest pain. We did her exercise stress, normal. Calcium artery score was like 500 something. When we took her to cath, she had triple vessel disease. Just was one of those weird things, did not expect that. Again, fairly expensive, just tell you about that. So when you look at who you have that has chronic coronary artery disease, we have medical management, we have things like PCI, we have bypass grafting. All of those are sort of our adjuncts. And we can look at how much risk of myocardium is involved as to where we go and what strategies we employ. And are there other comorbidities that we may need to take into account? So it's based on sometimes the number of the disease vessels and also the location. Age as a predictive factor is, again, we say older patients don't necessarily do as well, but they may derive an absolute benefit that's somewhat greater than the younger patient. So when they do well, but when they don't do so well. And so you have to just realize that stress testing may become our useful predictor in terms of both survivability and outcome. And so we can stratify them into the lower risk person that has normal LV function and normal EKG, no CHF symptoms, but has like the stable angina. You know when they're going to get it. They run outside to try and catch the bus, and they have an episode of angina. These are the patients that are at low risk. At high risk are those patients that have already documented LV dysfunction. They've got EKG changes. They may or may not have had a history of congestive heart failure, or they're having the increasing anginal episodes. And anybody that falls in the middle is sort of in the intermediate. And so, a patient with a New York Heart Class 1 symptom, you have to say, what's New York Heart Class 1, right? Left mainstem disease, the correct therapy is nitrates, angioplasty, coronary bypass grafting, testing first for left ventricular dysfunction. What do you think? And the answer is actually, it could be 2 based on some new recommendations. It could be B or C. We'll talk about that. So the old recommendation, New York Heart Class 1, 2. So New York Heart Class 1 is patient who is asymptomatic, or 2 with minimal or with moderate activity. They used to be if you had left mainstem disease, left anterior descending, or triple vessel disease, the recommendation was probably these are the patients you'd consider for bypass grafting. The new literature is saying it's acceptable to stent left main, left anterior descending. That's why I said the answers have changed. Triple vessel, probably still bypass grafting. If they're heart class 3 or 4, 4 is I have symptoms at rest, 3 I have symptoms with very minimal activity. These, regardless of the number of vessels, are telling you they're in trouble and they may need bypass grafting. If they're intermediate and they're not doing well on the medical management, you could consider PCI and combination medical PCI therapy. If they don't improve after that, they may end up declaring themselves as being bypass candidates as well. In the low risk, so New York Heart 1, 2, in the absence of LAD or left mainstem or single or vessel disease with minimal symptoms and minimal to mild LV dysfunction, these patients would again be treated medically and then stepped up to PCI, and if that fails, consider doing bypass grafting. So our guidelines here are we do all of this on the basis of our therapeutic lifestyle modifications. We do our blood pressure control. These are people that are in that category. They should be on a statin, and we're probably going to use a low-dose aspirin, 81 to 162 milligrams a day. In those patients that have already demonstrated LVFs less than 40, they probably should be on an ACE as well. And anytime you have a compelling indication, hypertension, diabetes, if they have concomitant heart failure or lower EF, they probably should be on an ACE. You get 2 bangs for the same buck. ARBs only if they can't tolerate ACEs. Beta blockers, again, now recommended if you have an EF less than 40. How many of you remember in the distant recesses of your past that when we first started, people with CHF shouldn't get beta blockers? Yeah, I have enough gray hair to remember that. I was taught never a beta blocker. And someone said, why not? And then when they did the study, they said, oh, look, they live longer. Another one of our sacred cows been slaughtered, right? Annual influenza vaccine, and I'd also add probably consider Pneumovax and Prevnar. Anti-anginal therapy, you can use nitrates, you can use beta blockers, you can use calcium channel blockers. Usually the calcium channel blockers are if the nitrates and the beta blockers haven't worked. If they're really symptomatic and you've already done bypass or PCI, they can do things like counterpulsion therapy, which essentially hooks you up to a giant blood pressure cuff, total body, synchronizes it to EKG, and it helps in terms of compression and bringing blood back into the venous return so you get better filling. Exercise stress testing really is used for, again, a couple purposes. One is to make the diagnosis. 2 is to evaluate our efficiency of our anti-anginal ischemic program. And you really want them to get to about a stage 3 of a Bruce protocol. That's a 10 MET equivalent. If they can do that, their annual risk is less than 1% mortality. So again, tells you that you're doing everything right. If you're looking at the angiography, it would be those patients that have ongoing symptoms that interfere with their lifestyle or that meet that high-risk criteria. And when you look at the results of coronary bypass versus PCI, in terms of overall mortality and morbidity data, they're pretty similar. PCI starts as preferred because it avoids the post-op surgical complications and the surgical morbidity. But they do have some risk for restenosis. Even in your drug-eluting stent, it's not zero. It's somewhere between 5 and 10%. If you look at the patients with a bypass graft, in a good patient that's well controlled medically, the average life expectancy of that graft is somewhere around 8 years. So these are the people you'll see that have had their first bypass. They're going for their second or sometimes their third. And the problem we're concerned about is as you start getting into that second and third episode, you can get some post-pump syndrome with some cognitive impairment, especially noted on very sophisticated neuropsychiatric testing. And so that's why there's some off-pump techniques that have been developed or shorter pump times. For most of those patients that are asymptomatic, you don't need to necessarily stress test them every year, but again, about 5 years is sort of the magic window where you start to see restenosis, and these patients may start having symptoms again. This is where we're going to end up, unfortunately, a lot of patients with heart failure. It's an easy definition. Pump doesn't work. 500,000 new cases a year, 2% of the population in terms of overall population, but 10% of those patients greater than 65. And a third of these get rehospitalized within the first 90 days, often within the first 30. You have to remember that's a no-pay diagnosis. And so the idea is to try and keep these people from that revolving door. They're in, they're out, they're in, they're out. Because if you look at this, as the patients get moderate or severe symptoms, their mortality approaches that of about 40 to 50% within the next year. That's a hospice diagnosis. And so it is the most expensive of our DRG-related groups for Medicare. I am not going to bore you with all the signs and symptoms. I am going to point out that sometimes the earliest thing you can hear is an S3 gallop. If the patient's in the left lateral recumbent position, use your bell and listen for that. That indicates the stiffening of the myocardium as the valve first opens and blood rushes in. You hear a thunk, and that's this S3. So when we look at this, and don't you love the decoders? Doctor, what kind of heart failure is this? Is it systolic? Is it diastolic? Is it acute? Is it chronic? Is it mixed? And I always wanted to say yes. Because sometimes it's really hard. The systolic is easy. Systolic dysfunction, dilation of the coronary, the heart, contraction is impaired, pump doesn't work. That's an easy one. There's the ones we see most of the time. These are ischemic in nature, so again, related to coronary artery disease, but they can all be post-infectious, post-toxin, and postpartum. And so you'll look at that. These are also the tachycardia-mediated CHF. So the patient that has a little bit of coronary disease that now goes into AFib and then goes into heart failure, this is systolic dysfunction. Diastolic dysfunction is the one that's the toughie because they can have normal to supernormal ejection fractions. You'll see an ejection fraction 55, 60% and say, hey, that's good. Well, maybe. And there is an overlap with some heart failure, so they can overlap with both having systolic and diastolic. In the systolic dysfunction, we know it's ischemia. In the diastolic dysfunction, it's hypertension. So hypertension, the hypertrophic cardiomyopathies, the amyloidosis of the heart, aortic stenosis, these are the causes that you'll see of the diastolic dysfunction. So here's a case study. 68-year-old, fatigue, shortness of breath, leg swelling over the last 3 months, chest pain when he climbs a flight of stairs. He has 2+ pedal edema, no murmur of irregular heart rate, mild cardiomegaly noted on a chest x-ray, left bundle branch block, his cholesterols are there, not great. And the question is, what category is he? And notice I use the AHA-ACC category. What stage? A, B, C, or D? And people go, what's the stage, right? So I'll come back and answer that. Here it is. If you look at why are we using the ACC AHA guideline as opposed to New York Heart? Well, if you look at everybody in this room is stage A. You're at risk. Isn't that scary? Or they have no structural disease or symptoms. If you look at B, so from B, C, and D, they all have ejection fractions that are decreased. B is they don't have symptoms, C is they have symptoms, and D is they have symptoms at rest. And the issue with why are we going to that as opposed to the New York Heart, which has been sort of the tried and true, is New York Heart, one is no limitation. Okay, so what's ordinary activity and what's minimal activity? There are some people that say, oh, climbing a set of stairs is minimal, and some people are going to say, that's ordinary. And so it tries to break out the B's and the C's to be a little better when you're looking at some of the studies. Why is that important? When you get somebody that has symptoms that rest with congestive heart failure, their 1-year mortality is up 60%. So again, just looks at, we can sort of stratify. The diagnosis is really a clinical one. Do you really think you needed to do a BNP on George? 2+ pedal edema, cough, shortness of breath, rails. Would you be surprised that his BNP was elevated? No. The BNP is really useful when you're sort of puzzled. I have my asthmatic patient who's come in, who's not in control, and who's coughing, shortness of breath, has a little bit of edema. Is it his asthma or is it his congestive heart failure? Oh, BNP's 1,000. Well, then you know it's probably cardiac asthma. Because where did we come up with the 100 picograms per ml? Anybody can show me that study where that was the cutoff? Was there consensus agreement of a bunch of cardiologists? So I always argue, if the patient has a BNP of 99, are they not in heart failure if they have 3+ pedal edema? Right? So it's very useful and it helps us, but it really doesn't. Their diagnosis of CHF is really still a clinical one. It's really nice to say, oh yeah, the BNP is 700, but so the BNP goes to 500 and the patient still has symptoms. Did the patient improve? Is there any correlation? No. Therapy, again, treatment of the underlying disease is paramount. So if they're hypertensive, get them into a normotensive range. If they're ischemic, do they need a PCI bypass? Do they need a valve replacement? Do they need a valvuloplasty? Things like lifestyle reduction of salt, alcohol, cigarettes, again, pneumococcal vaccines and influenza vaccines, and then looking at other medications, including over-the-counter ones that may be precipitating heart failure, i.e. things like non-steroidals. And patients don't tell you if they're taking the Aleve or the Advil unless you ask them. Our treatment for systolic heart failure, we've got pretty good evidence. You can do any of that list here. If anybody gets the American Family Physician, and I believe it was in this month's edition, there's a great review of systolic heart failure. It talks about the different medications and at what stage you would add them, whether it's stage A, B, or C, D. It's a really good article worth pulling out and looking at. But you can look at if they're really complicated, ventricular resynchronization, or a lot of these patients end up with AICDs as both a tachycardia modulator and also in terms of the fact that their ejection fractions are lower. They're doing a sequential pacing with or without antiarrhythmics, especially if the patient's already had episodes of either AFib or VTAC, or they had it's really a misnomer. It's not sudden death, it's near sudden death, right? Because if it's sudden death, it doesn't matter. And then some of these patients that are really, really severe, if you're really lucky, maybe on the transplant list, or doing things like counterpulsion or a ventricular assist device as a bridge to transplant. Okay, you can use the diuretics. You may start with your loop diuretics. If they stabilize, you can back down to your things like hydrodiuryl or hydrochlorothiazide. So you can sort of down-regulate them if they're stable. ACEs usually are in combination with your diuretics. Beta blockers, we know that some of the long-acting beta blockers, the things like carvedilol, extended release metoprolol also are very useful, and you can titrate them up. DIG, if they're still having symptoms, it's low dose. You don't need the higher blood levels. ARBs, if the ACEs don't work. Aldosterone antagonists have really made the comeback. If the EFs are between 30 and 35, these patients probably would benefit from an aldosterone antagonist. And some of the recommendations are yes, anywhere from stage C and on, or even sometimes B, depending on the symptoms. In certain select populations, your combination nitrate plus hydralazine, known as Bidil, may be useful at least in some of the African American populations. They show some less response to the ACEs, but better improvement with the combination, so that may be useful in certain population subgroups. Diastolic is a lot harder to treat. There's not the same evidence that we have on systolic. And so a lot of the trials with ACEs, with ARBs, with calcium channel blockers, with beta blockers really come inconclusive. And so the general agreement is we're going to use somewhat the same medications that we do for our systolic heart failure, but with, again, the point toward blood pressure control. And we want to address ischemia. So here's a 73-year-old, stage C congestive heart failure, systolic dysfunction. What could he, can he take ibuprofen for his aches and pains? What would you tell him? Answer, D, may cause fluid retention and precipitation of CHF. All right, a couple other topics we're going to talk about. So we talked about ICDs. What happens when the patient comes in and said, my ICD fired? First of all, I usually tell it hurts like crap. And so then the question is, was it single, was it multiple, and was it appropriate or not appropriate? Did it do what it was supposed to do? Or was this something that's a misfire, if you will? And so you have to look at, a lot of times, is there a change in clinical status? Do I need to get them back to our friendly electrician known as the EP guy? And then do I need to either reprogram that, or do I need to add antiarrhythmics in addition to the AICD? And so again, walks you through all that. Please don't do what my colleague does who plays ice hockey and her AICD went off and she went back out on the ice. That's like, okay. The bigger question, should they drive? If anybody does DOT physicals, they know if you have an implantable defibrillator, that's an automatic disqualification for commercial vehicles. But what about for patients that drive just routinely? You have to know what your state says. There's different regulations based on states. Most of them are going to say not for the first 6 months, certainly non-commercial driving. There's at least one study in the geriatric literature that says the patients that have AICDs actually have a lower rate of accidents than those that don't. Now that means they just drive more carefully or they're more conscious of what's going on. All right, murmurs, and we hear of this all the time. So the question is, who do you evaluate and who can you sort of watch? If it's a diastolic murmur, it's never normal, needs to be evaluated. If it's a systolic murmur and it's greater than 3/6, it probably needs to be evaluated. Again, if it's a very subtle, small one and the patient doesn't have any symptoms, it doesn't necessarily warrant that you have to evaluate, because a lot of these turn out to be flow murmurs, or there's, again, usually no radiation. And this is sort of one way to grade this. I always joke and say the 1 is what I can't hear anymore. I'm 60, I've presbyacuscus. The 6 is you walk in the door and you say, oh, it sounds like the grandfather clock ticking. It's usually have a valve as well, but sometimes you can hear that. And so you really want to just, as long as your 3 is always your 3, it's really more interoperable. And so how do we do this? Again, if you have a systolic with no symptoms, but the murmur is greater than 3/6, they probably should, they should be evaluated the transthoracic echo. If it's less than 3/6, they could be monitored. If it's a diastolic, it needs a transesophageal echo. Just sort of a way to hang your hat on how to work those up. We're going to a couple other topics. Pericarditis, inflammation of pericardium around the sac, if you will. Up to 50% if you echocardiogram have effusion. That does not mean they all need to be tapped. It just means that they have effusion. It's often post-viral infection, and so these patients will come in with a post-viral cardiomyopathy or pericarditis, and then usually you're treated either with a non-steroidal or steroids, but the problem is the steroid dose drops, you may get a recurrence of symptoms. If they have recurrent symptoms or they're associated with some of your rheumatologic diseases, then you may want to use a higher dose non-steroidal or even colchicine. And you can see this also post-MI, which is called Dressler syndrome. And Bob is going to talk fairly extensively on what are called killer foils. They're the things that suck you in on the test. You just like Dressler syndrome, what the heck is that? I don't know, that must be the right answer, right? Aneurysms and dissections, I think is where we're going to finish. An aortic aneurysm is arbitrarily, by definition, a greater than 50% increase in the diameter or greater than 3 centimeters. That's sort of our convention. And we look at the risk factors, they're the same as those of coronary artery disease. In younger individuals, it's those that have connective tissue disease, so Ehlers-Danlos or Marfan syndrome. But you can see it post-trauma and post-infectious. Remember the old syphilitic aneurysm? It's still there. Most of these are infrarenal, and most of these are more common in men. And it's usually an, oh, by the way, diagnosis. They had an ultrasound for abdominal pain. Oh, by the way, they have a 3.9 centimeter infrarenal abdominal aneurysm. And that question is, what do you do with it, right? Recommendation from Preventive Service Task Force is a B recommendation for any male between 65 and 75 who smoked to have a screening ultrasound done for an abdominal aneurysm. If you didn't smoke or you were a woman, it's either a C or a D. Women are D, don't do it. And so if you look at the Preventive Service Task Force, it's a pretty liberal definition of who smoked. It's like 10 cigarettes in a lifetime, something like that. It's pretty, again, and why do we make that important? Because that's a B recommendation. Unless we repeal ACA, it's still covered under A and B recommendations. So here's a 6 centimeter aneurysm. What do we do with it? See, extensively, it's a painful diagnosis. It's less risk. It's asymptomatic. It does not present an increased risk of rupture. These are often what? Asymptomatic. When we want to repair this is when it gets to be 5.5 centimeters or higher. You can look at the monitoring. The bigger it is, the more frequently you're going to monitor it, either with a ultrasound or CT. But again, you want to look at if that's enlarging in size. Even if they don't have symptoms, you may want to consider elective repair. Women, it's a little bit smaller. And you want to still do things like smoking cessation, beta blockers. The recommendations for or against aspirin, if you have another reason for using aspirin, like for coronary artery disease, again, this is equivalent, it'd probably be reasonable to do that. If they had back pain, groin pain, abdominal pain, and you know they have an aneurysm, they really need an emergent evaluation. They may be telling you that they're rupturing. And if you look at the differences between elective and emergent, the mortality is drastically, it's a 5-fold increase in mortality. If they have already ruptured and they're hypotensive, the mortality approaches 50% intraoperatively. So then the question is, can I do endovascular versus surgical, bypass graft, if you will? The endovascular repair is useful in only those that have infrarenal, and they have to have a specific good set of anatomy. So if it's a real tortuous aorta, it may not be as amenable to using the endovascular graft. And I leave that up to my cardiovascular colleagues that decide who does or who doesn't. When you look at the studies for open repair versus the endovascular graft, by 3 to 5 years, there's no difference. Early on, there's probably a difference more related to the operative morbidity and mortality. But at the end of that, they pretty much even out after about 3 to 5 years. We'll finish up with dissections. Type A, above the arch. Type B, below the arch. So it's type B is the descending aorta. You see this again, more of a male predominant to get the dissection, except if patients have Marfan syndrome or Ehlers-Danlos, they may be at increased risk. The presentation is either atypical or sometimes it's a sudden tearing, sharp sensation in the chest. And sometimes, again, you can see that even in young individuals, if we manage to miss a co-arc, which we really shouldn't, but it does happen. The risk factors here, again, listed. Pregnancy is one of those risk factors, as is cocaine use. So the other thing is trauma. So vehicular accident may increase your risk of dissection. And anybody that's had pre-existing diseases. Some of the findings: a widened mediastinum, an abnormal, if you will, aortic contour. There may be a double density, so you can see calcium in 2 places. So it looks like there is, again, almost a mirror image of the aorta. TEE is the best if the patient is unstable. You can rapidly get that. get that probe right next to the heart and see whether that dissection is expanding. If they're stable, MRA or CTA may be useful. Does anybody do angiograms anymore? Yeah, spiral CT, the thing. So again, this is a gentleman, 72-year-old, sudden onset of tearing chest pain, widened mediastinum in the superior aspect. He is stable, a pulse of 160 over, pulse of 95, blood pressure 160 over 100. The question is, what's the best treatment for George? IV dobutamine, oral enalapril, IV propranolol, IV hydralazine. What is it? C, IV propranolol. Yeah, type A, if you have a type A dissection, you need to get in the OR. Because if anything's above the arch and you're doing the major vessels, they have risk for stroke, limb loss. Look at the morbidity or mortality. 1% per hour after the onset of symptoms. So again, you want to get them. If they're type B and they're medically stable, manage the blood pressure and then get them evaluated for repair. And our initial blood pressure management is either IV propranolol, labetalol, or esmolol, IV beta blockers. We don't use the old hydralazine or the sodium nitroprusside because, yes, they lowered their blood pressure, but they caused reflex tachycardia, which actually accelerated the dissection. Peripheral vascular disease, just a comment, it is a coronary artery equivalent. A lot of these patients you can over and underestimate just based on physical exam and their history of claudication. Ankle brachial index is what's recommended. You can do that. And especially, again, the grading is there. Sometimes you will have patients that have non-compressible brachial arteries, so it's really tough to get an ABI. Our risk factor control, getting them into an exercise program. Some of these patients may be on medication. Some of these patients may even have stenting. And at least in our area, my cardiologists are doing stents all the way down to the popliteal artery so that they can do some of that bypass.